by family member caregivers, which one is worse? Doctors, and here I do mean doctors, not just providers. Doctors, which one do pain patients say is worse? Doctors being stigmatized by doctors or being stigmatized by loved ones? Loved ones? Doctors. They rate being stigmatized by doctors as worse. Why? Yeah! The white coat. You guys have the role. Society invests you with the role of the white knight, the white coat, the person who will come in and relieve suffering. And it's felt to be a more intense loss when these patients are disappointed over and over again. That's the power of this kind of stuff. Okay? So if you guys want to link this, especially for you bioethics students in here, to theories of bioethics that may be helpful. I like Powers and Faden's health sufficiency model of social justice. We won't talk a lot about what that is, I promise, because that's not what I do. But Powers and Faden, one of the things they say is, look, for all we talk about resolving or compressing health inequalities, we don't have a lot of good theories that help us answer the question of which inequalities matter most. That's a difficult question. We might have a whole bunch of health inequalities, and we'd still want to figure out, even if we want to address them all, which ones are most important, which one deserves more of our attention. Some inequalities are unimportant. There is a stark inequality in basketball talent between LeBron James and myself. This is not of concern to anyone other than me, nor should it be, okay? Right, so we have to figure out which ones matter, and Powers and Faden say, look, we have an answer. We have to focus on inequalities that fuel those densely woven patterns of disadvantage. Those densely woven patterns, those are the killers. Those are the ones that keep the worst off, and the best off, the best off. Those are the ones we have to address, okay? And so they say we really have to do two things. One, we have to try to improve overall population health, and we also have to compress health inequalities. And by the way, unfortunately, we're pretty good at implementing policies that do one but not the other. So for the classic example is reducing smoking incidence. So we reduced smoking incidence a lot in the 15 years, and that's good from an overall population health perspective. But then what happened to the inequalities in smoking-related disease? Who smokes now? Poor people. So what happened to the inequalities? They went like that. They went like that. So I'm not saying we shouldn't try to prevent smoking, by the way, guys. Don't say Goldberg said that because he didn't say that, okay? What I am saying is we should probably look for policies that do both of those things, that both improve overall population health and compress inequalities. Laws, policies, interventions, acts that intensify stigma fail both of these prongs. They both make people sicker and they exacerbate existing inequalities, right? So if you want to look for a model which helps us understand why this is probably unethical or at least ethically suboptimal, I think Powers and Faden's one works pretty well. Okay, so there are some moral obligations I think providers and basically all of us, to be honest with you, actually have with regard to helping people deal with stigma, to ameliorating stigma. So the first thing to understand, and here's usually where we get to the part of, well, what can you guys do about it? Right? I'm a ruthless pragmatist. I do public health, guys. So at the end of the day, I want to know, what can we do? How can we make this better? Okay, and so usually what I say here is I taketh away and then I giveth back. Okay, so first I'm going to take away. I'm going to tell you that you cannot resolve stigma on the individual level. You are not going to fix these deeply rooted upstream social structures, right, in your individual encounters with your patients. That's not how it works. Stigma is structural. Right? If we're going to actually target stigma, we have to have interventions that target its upstream macro-social roots. There are examples that I talk about in other talks and in some of my printed work about what some of those policies and interventions might be. Okay? But suffice it to say, we're not going to solve stigma on an individual level. We're not going to resolve it. So that's me taking away. Sorry, guys. But now I'll give you back. Right? Especially empowered individuals. So first of all, people can possess the agency to resist social scripts in everyday encounters with stigmatized groups, right? Just because we can't resolve stigma on the individual level doesn't mean that you guys as future providers have no power to resist stigma. You do. You absolutely do. So I talked about those anecdotes and those stories that we collect from fat people talking about what they do to prepare for a healthcare encounter. You should read some of those things because, like I said, they're pretty heartbreaking and affecting, okay? And yet the thing is this, you have to understand, this is a member of a marginalized group that has likely experienced stigma in a healthcare setting repeatedly before they've ever set foot in your clinic. So if they set foot in your clinic and they have a positive, affirming, non-stigmatizing encounter, you have done something for them. right? You have not resolved structural stigma because you treated someone well and you didn't stigmatize them. No, of course not. But there was a lot of power in the encounter you just had. That person, after probably many years of having stigmatizing healthcare encounters, just had a good healthcare encounter with you. And that has real significant power. That has real moral worth. Right? And so just because we can't fix stigma on the individual level doesn't mean we can't resist it in individual clinical encounters like the ones you guys will be having with your patients. Okay, so what can we do on the micro level, right? We can have a different conversation about what we can do on the macro level. We can talk more about that. What kinds of laws and policies should we be implementing to try to resolve these deeply rooted structures of stigma? On the micro level, there's probably a number of things we can do. So one, you can apply knowledge regarding the social patterning of behavior to clinical interaction. So this is anecdotal, but my prior position in North Carolina, I lived in an area that was very poor, very rural, and very black. Historically African-American, right? And so a lot of stigma, a lot of health problems in that scenario. And type 2 diabetes was very, very highly prevalent. The dean of my former medical school used to say that if you want to see an epidemiologic profile that looks like a place in the global south, you do not have to go to the global south. You can just go to eastern North Carolina, because the epidemiologic profile there looks pretty similar to a lot of those places. So very high prevalence of type 2 diabetes. And of course, what would happen is, and I've talked to many providers about this is anecdotal, but here's the idea that explains this. You know, they'd have their patients in the waiting room coming in to have their H1AC checked, and what are they eating? So in Eastern North Carolina, it would be Hardee's. Here it might be McDonald's, Jack in the Box, whatever it is, In-N-Out, you name it, okay? They'd be eating fast food in the waiting room, waiting to have their H1AC checked. Okay, so understandably, this made the primary care providers very upset and very frustrated because this was not an isolated occurrence. This was common. Okay? And so what happened was we started to talk about it, and then we started to ask some questions about why these people might be doing these kinds of things, right? And we started to think about things like, well, maybe it's an ultra commute. It was a very rural place. Maybe people have to come from a very, very far distance, and this was the only thing they had time to eat. Maybe they're working multiple jobs, okay? And this is really a cheap way to get a lot of calories. Right? So this was it. We started to talk about these kinds of things, and all of a sudden it completely changed the provider's attitude towards what was happening, and they reported that they went on and had a pretty good encounter. Okay, so again, anecdotal, but an idea of ways in which our knowledge regarding the social patterning of behavior can change and ameliorate the risk of stigmatizing already marginalized groups, okay? Two, we love to educate and train and program our way out of all of our problems, okay, in medical and health professional education. And honestly, to be perfectly honest with you, it doesn't really work that well, okay? That said, there's nothing wrong with education and training and programming. There's evidence that specific anti-stigma training and programming can have some impact. It's, again, not going to resolve all our problems, but there's evidence that it has some impact. Number three, listen to people like fat activists. I've talked about fat activists, but it could be anybody. It could be disability activists, right? It could be members of movements for racial justice, for example, right? Listen to these people who experience stigma commonly, right? Listen to them when they describe their lived experiences, especially if we're talking about healthcare contexts, okay? Number four, pay attention to the social structures that seem to sustain stigma. So we're talking about social structures that reproduce terrible, terrible inequalities. Okay, and I know not everybody thinks we should all be resolving inequalities, right? So of course there's some politics involved in that. But still, at least you should be watching out for the structures that sustain pre-existing stigmas, okay? And the last one, watch out for implicit bias. Okay, so one of my other areas of expertise is conflicts of interest. So I actually do maintain expertise on implicit bias in general. Watch out for it. That's often the way we think. Okay, this is a theory. We don't have tremendous evidence for it yet, to be perfectly honest. But the idea is, look, how do these social structures impact our behaviors? Why was it that all of those medical students who reported false beliefs about black people and pain didn't treat them very well, as it turns out, okay? And the idea is one of the pathways that this might happen is through the implicit biases. These social structures impact our unconscious feelings and movements, and clinical practice is highly ambiguous. We don't have to have a big change in people's professional behavior to have an impact on whether or not how patients are treated, right? It could be this or it could be that. It might just be a little nudge, right? And there's a lot of work out there to suggest that implicit bias might be one of the mechanisms that nudges us in those ways, okay? So these are the kinds of things that clinicians, I think, can do on the micro level, and then there are things we can all talk about doing on the macro level to try to change some of those structures as well. Okay, so that's it. Thanks for listening, and I'd love to hear some questions, comments, and concerns. Thanks,
Any
guys.
questions, comments for Dr. Goldberg?
So this might be maybe playing a little bit of devil's advocate, but in our training, from everything that you've been saying in the last 50 minutes, we are trained to discriminate populations of patients and treat them differently based on what they present with. How do we avoid the stigma? How do we avoid the stigma when we're taught to stigmatize in a certain way, because that is how we properly treat them. That is how we properly screen patients. That is how we, by placing them in that group, and then, you know, each group has their own drugs. Each group has their own procedures that they go through.
Yeah, so this is the problem. That's a great question. And I like devil's advocates too, by the way. So you don't have, please don't, you don't have to agree with me, right? So I think I'd say a couple things. I'd say it is exactly what most health professional learners are taught. You guys are taught pattern recognition, and that's actually not a bad thing. You guys should be taught pattern recognition, right? The human brain, now there's probably some AI that is maybe a little better, but the human brain for a long time has been the most awesome pattern recognition device on the planet. That's actually part of the problem with implicit bias and stereotyping. It's too good. It sees patterns sometimes where we ought not see patterns. So in and of itself, the fact that health professional learners are taught to discriminate, to define populations, right, and to allocate risks and benefits accordingly, in and of itself, I don't think is a huge problem. Here's where we get into the difference between difference and deviance, right? Marking out, first of all, we're trying to avoid the structures of power, marking out in-groups and out-groups. Here we're just marking a group on the basis of a characteristic, but hopefully we're doing everything we can to avoid marking it in terms of in-groups and out-groups. Although, again, sick people are almost always an out-group as sick people, right? That's what I'd say. I'd say the job is to do everything we can to stop the stigma train. We know we're not very good at that on a social level, but it doesn't mean we can't cultivate that practice as individuals. Right, and say, look, I have to do this. I have to recognize this pattern and treat people differently. I mean, it's called a differential diagnosis, right? And treat people differently on the basis of the patterns they identify. But I am going to do everything I can not to track that into judgments, not to track that into negative judgments against people on the basis of the patterns that I identify. So it's a hard thing to do, but that's where individual agency comes in. That's where I think awareness of what stigma actually is can help. That's my best answer.
One more question, and I promise to watch my step here.
I have a question about the smoking law and hitting the two prongs.
Oh, yeah.
So you talked about how it did really good at improving overall health by making cigarettes less available or whatever. Could you give an example of how legislation could be written to hit two prongs?
Absolutely. So there are two examples that I usually use that I think are great. One is historical and one is contemporary, right? So the historical example I often use is sanitation. By the way, sanitation, probably the best health intervention in human history, to be honest with you. When we look at the burdens of waterborne disease, and I don't just mean like terrible things like cholera, I mean diarrhea, which kills young people and old people in droves, really, right? So sanitation, well, what happened is before sanitation became spread out in American society, who had access to sanitation? Wealthy people. Who didn't have access to sanitation? Poor people. So you had this social gradient, right, in health as it related to waterborne disease, which was very powerful, right? And so then what happens is we start to equalize sanitation. We start to give more people more access to sanitation. So what happens when we give more people more access to sanitation? What happens to everybody? Everybody gets better off when we give people access to sanitation, right? But then who needs sanitation more, poor people or rich people? Who benefits more from sanitation being equalized? Poor people, because they have less access to it to begin with. So everybody's better off, and then what happens to inequalities in waterborne disease? Everybody's better off, and poor people benefit more than rich people. That's an example. A contemporary example that I often use is early childhood development. The epidemiologic we have for intensive investment in early childhood development from age 0 to 2 is unbelievable. If you get a room full of epidemiologists and you start talking about this, no one will utter a peep of dissent. It's amazing. You want to see academics not argue with each other. Get a room full of epidemiologists and start talking about early childhood development. Silence. That's how good the evidence is, right? The evidence is so good that there's a Nobel laureate economist named James Heckman who has actually made this his project. He said that if he could invest in a Fortune 500 company today or do intensive investment in early childhood development, he would easily pick the latter because the rate of return, of economic return on intensive investment in early child development is like 13%. It's almost twice what Fortune 500 companies make in a good year, right? So the example is, who has better access to early childhood development, poor people or rich people? Who has more resources for children, poor people or rich people? Rich people, right? So if we give intensive investment in early childhood development, what will that do to our overall population health outcomes? It'll make everybody better off. But who will get more benefit, poor people or rich people? Poor people. So what will happen to our inequalities? Right? So these are examples of policies which looks like they will lift everybody up, improve overall health, at the same time that they compress existing inequalities between poor people and rich people. And so those are the ones that I and others have been saying. These are what I would call ethically optimal health interventions. This is, according to this model of social justice that I like, these are the ones we should be prioritizing. It doesn't mean we should ignore other ones, right? We shouldn't, but these are the best ones. The class of interventions that works best are the ones that lift everybody off and that compress health inequalities. Not everybody agrees with that, by the way, but that's my view.
This has been excellent. Thank you so much, Daniel.
Thank you all. Thanks for